Hi, welcome to the section of cardiology. This is Dr. Jaitly. Here in this section, I'll be talking to you about very briefly the basics of aortic regurgitation, as it's called AR. The causes are, well, number one is rheumatic heart disease, where the aortic valve, here in this schematic as I'm showing, shows the affliction of the rheumatic fever in childhood, which later on develops an aortic lesion and results into aortic regurgitation over a period of time. Degenerative, of course, with the old age, the aortic valves wear and tear occurs and they may get calcified. Sometimes they may become immobile, and any of these trileaflets can result into regurgitation phenomenon. Same thing is true with the congenital variety, where the bicuspid aortic valve, which is the aortic valve here, and if it's bicuspid, it tends to calcify or also tends to degenerate rather more acceleratedly. Infective endocarditis is a very common cause where the infection can seed in any of these valves, normally accompanied by mitral regurgitation endocarditis as well, in those settings where the left side is involved, and that infective endocarditis is seen as obviously bacteremia and vegetations here, and those are the major criteria to diagnose clinically whether somebody has infective endocarditis and aortic regurgitation as a result. Aortic root dilatation is an important entity where the hypertension and Marfan syndrome, the syphilis, the rheumatoid arthritis, psoriasis, etc., can lead to one to develop an aortic regurgitation because the aortic root dimensions are beyond the normal limits, and obviously once the annulus is dilated, it tends to calcify, even because of the lesions, and sometimes just the annulus itself displaces the aortic valve leaflets, and therefore they don't close tight during the diastole. So basically, what is aortic regurgitation? We have enumerated the causes, but let's understand what is aortic regurgitation again. It's the failure to close the valve completely during ventricular diastole, which is left ventricular diastole. Now, as a result, what happens is when the left ventricle is relaxing and the blood is returning back into the left ventricle, which normally should not, that is called aortic regurgitation. And when it returns back, the ventricle is already filling up from the left atrium, remember, during diastole. So you have a fill-up coming in normally from left atrium, fill in, and then now you have a regurgitant jet coming in from the aortic root, which normally should not have occurred. So you have two ways of left ventricle filling, which is not good. So the left ventricle starts dilating over a period of time. Now, normally this goes on for years and patients may remain asymptomatic. But when they become symptomatic, then obviously the signs are different, and then patients can start to have breathing on difficulty, on exertion, or laying down in bed. Sometimes they may have head bobbing, pulsations in pupils. Patients have complained of pulsations in the chest when they lay on their left side. And then there are signs like you could see pulsations in their pupils of the eye, the uvula, in the mouth, or even on the nail beds, one can see pulsations. A soft decrescendo murmur, which is decreasing in intensity from the onset of the murmur. It's in diastole, and that occurs at the apex, and the apex is also displaced downwards and outwards in the chest. Let's shift to the right side here. The aortic root happens to be here. Aortic valves are right here in this region, and one sees that as the blood is going up into the outflow tract, some blood will return back, and that results into LV dilatation. Some of the most dilated or biggest LVs that somebody has seen are in aortic regurgitation, actually. Okay, so that is just a point of pearl here. That largest LVs, that's why I've shown the LV here, the largest out of the entire 4 chambers, you see. So that's called the LV dilatation, which is a very, very noteworthy feature. And so also the left atrial dilatation, that will occur later. On the 2D echo, so one sees LV and LA dilatation, and the AR jet. The AR jet, because in diastole, the jet will be appearing like a colored mosaic pattern in this region. And depending upon how severe it is, how intense it is, and how far does it go to the cavity or towards the apex, will determine the severity of the aortic regurgitation. So in a nutshell, it has the causes are rheumatic and infective endocarditis as the commonest. And then, of course, aortic root dilatation. Clinical features are that there is a soft decrescendo murmur heard at the apex, which is in diastole. And then on the echo, one sees an aortic regurgitant jet, which is returning back towards the cavity or towards the apex. And depending upon how far does it travel, will define the severity. Okay, so these are the basics of the aortic regurgitation, and please supplement this with extra knowledge from the textbooks and elsewhere in the journals, and of course we'll be talking and updating you further with treatments, etc. at a later time. Thank you so much for your attention. Bye.